Well, as you know, there is a huge problem with diabetes with regard to cardiovascular disease. And cardiovascular disease is the main cause of death in diabetes patients. And diabetes increases the risk of, or diabetes patients have up to fourfold increased risk of cardiovascular disease compared to persons without diabetes. So it's obviously a very important aspect to consider in our clinical daily day, because a lot of our patients have diabetes, and we know in patients with myocardial infarction, up to 25% of those have diabetes or pre-stages to diabetes, and that's the same issue in patients with heart failure. There are also a lot of comorbidities, cardiovascular comorbidities in patients with diabetes. They have hypertension, they have hyperlipidemia or hypertriglyceridemia, they have overweight and obesity problems. There is often problems with sedentary lifestyle, and they have another challenge, which is blood glucose dysregulations, and many of them, and that's often associated with lifestyle, are also smoking. So there are a lot of issues about diabetes patients with cardiovascular disease. And we know they have increased risk of coronary artery disease. They have often a complicated coronary artery disease. They have three-vessel disease. And we know in regards of revascularization, they often need coronary artery bypass surgery. And then they also have increased risk of cerebrovascular disease, transient ischemic attacks, and strokes. And there is also the issue of vascular dementia, which is increased in patients with diabetes. They have small or multiple vascular strokes. And then there is another issue, and that's peripheral vascular disease. There's increased risk of claudication and increased need of amputation in patients with diabetes that are poorly regulated and have decreased circulation in the limbs. And then there is the issue of heart failure and diabetes. We know about diabetes cardiomyopathy, which is a complex phenomenon, and they also have hypertension that obviously increases the risk of heart failure and also ischemic heart disease. And there also been conflicting data about atrial fibrillation, and I will show you some data from our own group that we are currently working on, and that is the increased risk of atrial fibrillation. And that's important to consider because we know that in patients with atrial fibrillation, diabetes is included in the CHADS-2 score, and in patients with current diabetes and atrial fibrillation, they have indicated to be started on oral anticoagulation treatment to prevent strokes. And then there is the whole issue that I will not address here. It's about diabetic kidney disease and microvascular disease. So there are very important aspects with regards to diabetes. And these are data from our own group. They are from 2008 and published, and where we wanted to look at the issue of cardiovascular risk in diabetes. There was a study by Hafner that indicated that patients with diabetes had a similar risk as patients with established cardiovascular disease. And we wanted to test this dogma, or this hypothesis. Hafner's study was rather small, only included about 2,500 patients, and we did this nationwide study using our registries that I presented previously, and included the whole Danish population, about that was older than 30 years. That's about 4.5 million individuals included in the study. And we divided patients into those who had not diabetes or previous myocardial infarction, and patients with diabetes, and patients with myocardial infarction, and patients with both conditions. And we stratified our studies because there was an interaction with sex in our analysis to present data on separately for women and men. And as you can see here, I'll try to talk on the green line here. That is the background population, and they have the lowest risk, and it's stratified by age. These are 10-year intervals of age up to 90 years of age, from 30 to 90 years of age. And this is the risk of the combined endpoint of, no, this is the risk of cardiovascular mortality. And here you can see the green, the blue and the red line, they are superimposed. That is, these are, the red line indicates patients with diabetes, and the blue line indicates patients with prior MI. And as you can see here, they have the same risk of cardiovascular death. So the presence of diabetes puts you at the same risk as patients with previous myocardial infarction. And what is important to look at, those are the youngest patients. Those are patients under 50 years of age. They have substantially increased risk. And if you are so unlikely to have both conditions, that is both myocardial infarction and diabetes, you have this brown line here, and you can see that the risk is much, much, much higher. And this is the same for men and women. You can see that the risk is slightly lower for women compared to men. But within each gender, diabetes and myocardial infarction puts you on a considerable risk. So these are very therapeutic challenges for us as a cardiovascular doctors to take care of these patients. And these are it's the same population. These are the relative risks, and these are for women and for men here. And you can see that the presence of diabetes, you have about 2.5 to 3-fold risk of cardiovascular death. No, this is the combined endpoint, excuse me, of risk of myocardial infarction, stroke, and cardiovascular death. And for if you are a woman with both conditions, you have a very high risk, 5 to 6-fold risk of cardiovascular death, stroke, or myocardial infarction, and for men, slightly lower. So these are very patients we need to take care of. This is another study we did, and we wanted to look at, does it matter, does the risk decline from the point of diagnosis and during time? And we divided this into two periods from 1997 to 2001 and 2001 to 2006. And you can see we divided those into myocardial infarction patients, females and males, and these are diabetes patients. And you can see for a patient with myocardial infarction, the risk declines from the time of diagnosis and later on. And this is in both periods. This is the relative risk compared to the background population. And after about 1.5 years after your myocardial infarction, you have a very stable risk. But you can see for patients with diabetes, you have a very continuous risk of cardiovascular adverse events. So these are patients that have a continuous challenge, therapeutic challenge. These are patients after myocardial infarction. These are not our own data, but you can see divided into patients with diabetes and no diabetes after both STEMI, that is ST elevation myocardial infarction, and non-ST myocardial infarction or unstable angina. You can see that the deep diabetes, those are the thin lines, and you can see if you compare the ACS patient and the STEMI patients, that diabetes increases the risk during the first year considerably. And these are other data from our own group, where we looked at it over a long time, up to 16 years after the myocardial infarction, and you can see the survival in patients without diabetes compared to patients with diabetes. They have a very, very higher mortality. And when this is a landmark analysis that we started the analysis again and again after 2 years intervals, and you can see that the impact of diabetes during long term, those are patients without and with diabetes, and this is the risk of death, there is a continuously increased risk. So the impact of diabetes, it continues during time. If you survive 16 years after your myocardial infarction, you have still a very higher risk with diabetes. And this is another analysis where you stratify patients according to myocardial function, that is left ventricular ejection fraction. These are patients with under 75% of LVF, and those are patients with over 50%. But you can see these are patients without diabetes, and these are patients with diabetes. The impact of diabetes is the same relatively for patients with low or high ejection fraction. Another issue is clopidogrel and diabetes. And it has been proposed that the effect of clopidogrel is not as high in diabetes patients as in patients without diabetes. And this is another study we did that was published very prominently in JAMA, where we divided patients according to diabetes status. These are diabetes and non-diabetes. And you can see that the protective effect of clopidogrel is less in diabetes patients compared to patients without diabetes. And we see it on all endpoints, and this is a propensity score analysis, and you can see these are patients without diabetes, and you can see that patients who are using clopidogrel, that's the stippled line here, they have a lower mortality compared to patients with not using clopidogrel, but you can see that this effect is not prevalent in patients with diabetes. So it seems that patients who are receiving and not receiving clopidogrel have the same risk in diabetes patients. So it seems like there could be a lesser effect of clopidogrel in these patients. And then there is the issue of diabetic cardiomyopathy. There is a complex effect of diabetes on the myocardium. And it's not fully understood, and we don't know what to do with it, how we are going to treat it. There is some evidence that metformin could have a beneficial effect here. And we divided patients according to, these are heart failure patients, according to severity of heart failure and the risk of developing diabetes. And these are patients in group 1, that is with the least severity, and those are patients in group 5, that is with the higher severity of heart failure. And you can see that they have a very much higher risk of developing diabetes after discharge from a heart failure. But it's important to see that group 5, that is those with the worst severity of heart failure, they have a twofold higher risk of developing diabetes compared to group 1. But when we stratified patients according to if they received ACE inhibitors and not, we could see that ACE inhibitors in all groups, patients receiving ACE inhibitors or angiotensin II receptor blockers, they had a much lower risk of developing diabetes compared to patients who are not receiving ACE inhibitors. So it seems like not only are ACE inhibitors beneficial on the prognosis in heart failure, but they also lessen the risk of developing diabetes. And that's important because this is not our own data, but it is data from Teresa McDonald that shows that the risk that the impact of diabetes in heart failure it's associated with much worse prognosis. And then there is the whole therapeutic challenge of how to treat diabetes patients. We modify the risk factors. They should stop smoking. We treat their blood pressure. We achieve lipid goals, and we recommend them to exercise and lose weight. And then there is whole pharmacotherapy issue. They should receive ACE inhibitors or angiotensin receptor blockers, statins, and maybe antiplatelets and aldosterone receptor blockers. And there is issue of glucose-lowering therapy. So we have looked at that. Does it matter which type of glucose-lowering therapy they receive? And we have the metformin that was previously contraindicated in patients with heart failure or cardiovascular disease due to the risk of developing lactic acidosis. And then we have sulfonylureas drugs and incretin-based drugs, that is GLP-1 agonist and DTP4 inhibitors, and then there is insulin. And we see after myocardial infarction, we see that these are unadjusted analyses, but it seems like patients that are receiving metformin after myocardial infarction have a much better prognosis compared to patients receiving sulfonylureas or insulin. And we've looked at this, and we have stratified patients according to those who are not having myocardial infarction and patients who had a myocardial infarction. And this is the combined endpoint of stroke and cardiovascular death. And we see that compared to metformin, it's a reference here with a hazard ratio of 1. It seems like all of the sulfonylurea drugs, except glycosides, increase the risk of death, cardiovascular death, myocardial infarction, or stroke. And we find these are patients with heart failure, and here it's slightly different, and we wanted to test if metformin was safe in this population. And here sulfonylurea drugs are the reference, and here we have used also combination treatment. Does it matter if we combine different drugs? And you can see that metformin has a lower risk as a single therapy, and also that if you add metformin to a sulfonylurea or insulin, it seems like patients have better prognosis in heart failure. So it seems like a metformin could be beneficial in heart failure, and we are currently in Denmark starting a randomized clinical trial where we are randomizing heart failure patients to metformin therapy or not, to see if it's beneficial, if it can postpone the development of diabetes, and if they have a better prognosis. And lastly, these are unsubmitted. These are submitted data, so it's not published yet. But this is the risk of atrial fibrillation in diabetes patients compared to the background populations, and we see that. And these are stratified by age. These are patients 18 to 40 years, and 40 to 65 years, 65 to 75, and 75 to 100 years. And we can see that in the youngest population, diabetes increases the risk of atrial fibrillation with a hazard ratio of 2.3, and the impact of diabetes on the risk is lesser due to more advanced age, probably because there are other risk factors that could be more important in the elderly population. But this is the largest study to actually look at this problem, and it seems like that diabetes increases the risk of atrial fibrillation. And this is important because exactly in this population, there is an indication if they have atrial fibrillation and diabetes, they should receive oral anticoagulation therapy. So it could be beneficial to screen diabetes patients for atrial fibrillation to start prophylactic therapy, and thereby we could reduce the risk of stroke. So just to conclude, ladies and gentlemen, we find that diabetes is an important comorbidity in cardiovascular disease and is associated with higher risk of adverse events and mortality. But diabetes remains a therapeutic challenge. We require more intensive cardiovascular prophylactic pharmacotherapy, and we need more information of appropriate selection and on glucose-lowering drugs to improve prognosis. Thank you very much for your attention.
Thank you very much, Professor.